Hello. Hi. My name's George. Here's my patient. This will be our last video, so let's get right to it. So, over the past weeks, we've learned from my patient that she doesn't have no current diagnosis. She has a history of sometimes having the flu, which is fine. Usually, people have the flu once a year, which is completely healthy. That's not a big deal. Um, Other than that, we've learned that she has history of maybe sinus problems, right? Sinus problems
Yes.
and cholecystectomy. You had your gallbladder removed. Okay,
In
so
2006.
so that would be it. Usually, when I'm in the nursing home, doing my head to toe assessment, I before going in, I read the notes and look at the diagnosis and history, and I base off of that to see how I can do my head to toe. But this will be just a general head to toe. So let's start by the vital signs. I always forget my pen. Okay, 120 over 72 and pulse 63. So these are within normal limits. 120, the top number, the systolic number would have to be between 120. If it goes above 130, then you should go see a doctor for hypertension signs and symptoms. We try to keep the blood pressure below 150 when we're talking about the top number, which is the systolic number. Or even when it goes under 100, it would be considered hypotension. So I would, advise to go see the doctor. And usually the top number is what we're worried about. The pulse, normal range 60 to 100, so 63, that's fine. Take your temperature. 98.0. So that would be normal. If it would be over 100, then you go see the doctor or take medication such as Tylenol or ibuprofen to reduce the temperature to normal range. If it was below 96, then I'm advised to go see the doctor. That's very abnormal. Okay, so now what I'm going to do is just check the respiratory. I'm going to put a stopwatch real quick because I forgot my watch. We should always have a watch, I know. Okay, so we'll just like this and just breathe normal. Okay, so I'm just going to do it for 30 seconds. And that was 10, so 20 times 2. And just usually we use an O2 stat, for respiratory issues. So just put your finger there and let's just read it real quick. Just some extra vital signs. So 99, Normal would be 94 to 100, so 99 is perfect.
Awareness.
Yeah. So the final vital sign, we would ask, are you having any pain right now, from a pain scale from 0 to 10, 10 being the most painful that you feel. How do you feel right now?
I feel no pain.
So
it'll be a 0.
0. Okay. So after that, we ask her the questions to check mental health and orientation. So I'm going to ask him. We already went through that last video where maybe she should go see the doctor. I don't know, but hopefully she'll know the date today. Okay, so what's the date and time?
Oh, today's Saturday. The time is 5:40, and it's November 25th, 2017.
Okay, and what's your name?
My name is Julia.
Okay, so that's fine. So she's oriented times 3, which would be time, place, and person. What we've lately been doing is asking the person for situation. So we'll ask if she has a diagnosis, if she knows her current situation, and then that would be alert oriented times 4. But as I said earlier, right now she currently doesn't have a diagnosis. She's in a healthy state. So we'll just go with alert oriented times 3. So from there, start with inspection. I'll start with the head. So just bear with me. Take a shower, right? So what I'm inspecting is for any bruises, bumps, lacerations, abrasions, anything that's abnormal. Hopefully she doesn't have lice. Just kidding.
None.
Okay. So that's what I'm just looking at. Look back of the ears. Usually with women with long hair, we try to just pick up the hair, check the neck. No pain?
No.
Okay. No pain?
No.
Okay, so be considered normal cephalic. After that, I would go into using the pen light to check for the pupillary constriction. We see that she has glasses, so I'll note that here. Glasses noted.
Are you going to take them off?
Yeah, just to do the pen light test. Okay, so usually sometimes because I work in a nursing home, it's my current experience. Yeah, with geriatric patients, sometimes it'll be hard to get some pupillary constriction, so we could dim the lights. But for now, I'll just look forward. Look at them. Okay, perfect. Constriction. So just checking right here, it'll be 3 millimeters, so that's fine. Constriction. Oh, and let me do the H. So just follow the pen light to check for oculomotor. Okay, so her eyes are fine. She was looking into it, and now I'm gonna check for accommodation. So just look at it. Okay, so accommodation is just looking for a pupillary constriction as the pen goes closer. Okay, so from there, let's see what else we're gonna look at. Trimetry, head, facial expressions, symmetric. That's fine. You can see the nose symmetric, the eyes are symmetric, cheekbone, jawbone is symmetric. Okay, so we're just gonna check the mandibular. So I'm gonna palpate, see if there's any tenderness or pain, lumps, anything abnormal. Any pain?
No.
And now that I'm here, I'm just gonna check the neck as well. The same, like I said. No pain, no tenderness. No inflammation on the nodes. I mean, can you swallow?
Yeah. I did.
Oh, okay. Okay. So any pain while swallowing, anything like that?
No.
No. Okay. So usually, difficulty swallowing could be tonsillitis. Inflammation of the tonsils. That would be one thing we would be checking at. Can you go like this? Check in the nose, checking patency. Now the other one. Okay. All right. So patency to both nostrils. No nasal flaring noted, which could possibly a respiratory infection or anything like that. Let me see what else I could. I'm going to check. Okay, so no. Right now, I was checking the neck. No thyroid enlargement or hyperthyroidism or goiter. So that would be just a big lump on your neck. you know, that's what we're looking at. So no tenderness, no swelling on the lymph nodes. Able to swallow properly. So going back, I'm just gonna just do the overall of the eyes. Just keep going back and forth. Going back to the eyes, the sclera is fine, white, no jaundice noted, no yellow discoloration, which would mean probably something going on with the liver, cirrhosis, anything like that. Um, so vision is fine. Do you have any problems with eyes besides wearing the glasses?
No.
Okay.
No problem.
What did they tell you? What do you have? Why do you have to wear glasses? Do you have the astigmatism?
I have stigmatism.
Astigmatism.
Mhm.
Okay, let me write that down.
I'm just the reading. I used to mix the reading. I was using the computer a while ago.
Okay. Be a astigmatism, be a curvature of the lens. Fortunately, because I'm her son, I got it too. So I have to wear glasses too when I'm driving.
Mm-hmm.
But anyways. Anyways, other than that, any other eye history, glaucoma, any other problems with vision, anything like that,
no.
double vision?
No.
Okay. Okay, so we're looking at the eyebrows, eyelashes, eyelids. No lid lag, no swelling, no lesions. So everything's symmetrical when it comes to the eyebrows and the eyelashes. I'm just gonna check real quick. Okay. Okay. Can you look up? I'm just gonna palpate right here on the lower eyelid. Any pain?
No.
Okay. And I did wash my hands. I did wash my hands. Provide privacy. Doors closed and gloves. I currently don't have gloves, but I wash my hands. All right. Let's see. Okay, no problem there. No swelling, no redness. Lacrimal gland, which would be here, the inside. It would be right here on the inside of the eye. Okay, no drainage. Let's see. Sclera white. No exudate. Or like going back to the pus drainage or anything like that. Anything abnormal. Okay, so we're gonna go to the ear. So right now I'm just gonna check the back of the ear. If she has any problems like I did earlier. She didn't. Looking inside, nothing there. I would look at the other ear as well for any abnormalities. Just by looking at it, it seems symmetrical. No problem. No drainage. No anything. No redness noted. Anything like that. Any ear pain?
No.
Any ear pain? Okay.
No.
Okay. So we're gonna do just the whisper test. So I'm gonna just whisper something, and then you see if you can hear it.
Mm-hmm. 99.
Alright, so I said 99. I whispered it. There's a whisper test, just checking for hearing loss or anything like that. Other tests would be Weber and Renai test, which would be used with a tuning fork. Unfortunately, I only have penlight. So the nose already palpated, no deformities there, no problems. Let me see. No swelling. Okay. No pain. Already checked for airflow, patency. Okay, so now the lips. They seem moist, pink, no issues there, no lacerations, abrasions, any abnormalities. It seems fine. So now we're going to check the oral mucosa. So you can please open your mouth. It's like a pen. Shut up. Okay. Now pick up your tongue. Okay. So I don't know if you could tell, but she has braces on. But I mean, no, nothing else out of the ordinary. Her oral mucosa is pink and moist, no problems, no ulcers, no white patches, no the tongue pink, no problems there. No going back to tonsillitis noted at all. Tonsils are fine. Nice pink red, no inflammation noted. Um, no halitosis noted. Bad odor. So you washed your teeth. Okay. Okay. Can you move your tongue side to side? Okay. So no problems there. Okay. So the oral mucosa is fine. No abnormalities, like I said, with the tongue or the gingivae. No edema and like gingivitis or anything like that. Do you have any history of smoking?
No.
No history of smoking. If the patient would have said yes, then we would give a history on it that smoking is a stimulant, so it raises the pulse and can create problems with the lungs later on. If continuous consumption, we would give advice to maybe try a nicotine patch, something to just decrease it from there. Also, nicotine also produces problems with the oral mucosa. It causes the yellow teeth. You know, every little common thing that the common person might know, but you know, it'd just be like a small refresher. So, okay, so we're done with that. Now what we're gonna look into is the lungs. So her respiratory rate was fine. Her O2 stat was fine. No orthopnea, difficulty breathing, paroxysmal nocturnal dyspnea, difficulty breathing at night. Do you have any chest pain, anything like that? Any history with any lung problems?
No.
I've always been able to breathe fine.
Yes.
No chest pain at all.
No.
Okay.
No.
Okay, so we're already looking at the thoracic as well. So we're looking for symmetry. The chest seems symmetrical. Everything seems in place, intact. Do you have any bruises, any skin issues,
no.
Lacerations, abrasions, scrape marks, scars, anything in the chest
no.
area? Okay. No wheezing, no dyspnea, going back to respiratory issues?
No.
Nothing like that? You don't have history of asthma or anything?
No.
Okay. Okay, so what I'm doing right now is just inspecting, like I said, when I was checking for symmetry. No muscle retractions, no labored breathing. Muscle retraction would be using most of the abdominal muscles instead of the diaphragm. So she looks like she's breathing fine. No problem there. So right now, because she's a woman, I'm asking her questions. She's alert oriented times 3, so you know I don't have to palpate or anything like that. She could just tell me for tenderness or lesions or any pain issues like that. Let's see. Okay, so right now I'm gonna auscultate. That would be second, and I think it's palpation and percussion. I need to look at that again. So usually when we palpate, it would be here on the right side, on the outside of the right side, maybe right upper quadrant of the chest, and then on the other side outside. And then as we move in, it will be inside the breast region, and that's what we would best be looking for any respiratory issues or anything like that. Going back to, bronchi, wheezing, anything like that.
Mm-hmm.
So just take a deep breath. Okay. Okay. So she's breathing fine. No problems there. No crackles noted. Anything like that. No congestion noted. So healthy state. So now I'm gonna look in the back. So usually in the back it would be the same thing, maybe in the middle between the scapulas. So that's what I'm gonna do right now. And there's like maybe like I think it was like maybe 12 points where we can check in the back, but I'll just check 4 for now. And we usually tell the patient to take a deep breath. So go ahead. Okay, so anterior and posterior, normal breath sound. No issues there. I'm gonna put those. Okay, so bronchi normal sounds. Let's see. Okay, we already checked the neck. Okay, we already asked if any problems with the chest, any edema, dyspnea, orthopnea, cough, congestion, diaphoresis or sweating, fatigue, edema or swelling, nocturia, palpitations, chest pains or anything like that. Okay, so the apical pulse usually would be in the fifth intercostal space, mid-clavicular line. So the clavicular is right here. The intercostal space would be under the breast region, and we would auscultate it for 1 minute. Okay, so can you do me this favor? Just place it. You place it where I told you. Move it right here. Yeah. And I'll just listen for the minute. I'm gonna put a stopwatch. So 1 minute, I got 61. So I think earlier it was 63. So still within normal range, so that's fine.
Okay. That's a lot.
Yeah,
Of writing.
it's gonna be a long head to toe documentation. Okay. Okay, so before we leave the chest area, going back to any problems or anything like that, usually blood pressure, hypertension would be like the most common in the valley. So let's just say she had high hypertension, which would be above 150. I think my grandma's the one that has
Mhm.
a history of hypertension, so she
Mhm.
takes medication, atenolol, uh, what else, losartan, those types of medications. Um, so what would we or how or what would we educate to that patient, right? Well, we would educate, diet, exercise, uh, exercise meaning maybe for an hour a day, 30 minutes at least walking. Jogging is always strengthens the heart. The diet would be, your regular salads, fruits, vegetables, anything like that. Um, steamed chicken, just nothing that's fried or anything like that that could raise your blood pressure. What else? Also, just if I think my grandma has a fluid restriction also because of the hypertension and problem issues, cardiac issues. So that would be another thing because the more fluid or salt intake, which retains the fluid, increases the blood pressure. So we would just give education on that, education on the blood pressure medications. Every time that I discharge a patient or anything like that, we have to give patient teaching on medications. So going back to atenolol, um, and in that particular medication, we have to check both the pulse and the blood pressure. So let's say the blood pressure, the systolic number would be lower than 100. Well, then we would tell the patient or advise to not take the blood pressure medication because if she takes it, it's gonna just drop it even more, and then you're just gonna feel fatigued, you're gonna feel bad, lightheaded, and we don't want that. Also, the pulse, if it's below 60, we don't want that either. Bradycardia, which is low pulse below 60, we don't want that either. So we give patient teaching. But like this, you're not on any medications, right?
No.
With blood pressure or anything like that.
No. No.
Or also cardiac issues would also have Lasix. Going back to the fluid retention, we would give Lasix, you know, so she can get rid of the fluid. Um, let's see. Okay, so what I'm gonna do now is before going to the abdomen, I'm gonna check the upper extremities. So I'm right now like we're gonna inspect. So I'm just inspecting
Mhm.
any pain. So,
Mm-mm.
nothing.
No.
Fine. Okay. All right. So skin intact, no problems. Her fingernails. We check the capillary refill, which should be less than 3. This is checking for circulation. If it's above 3, then that means improper circulation. So I'm blanching it, and it goes back to the pink color, so that's perfect within 1 second actually, so that's fine. So let's do range of motion, like we did with the musculoskeletal. So just go like this, go up, me. Can you put your hands? Okay, stretch them out. Go like this. Okay, I'm gonna put it down. Okay, okay, the pronation, everything's fine. Now range of motion on the wrist. So go down like that, pick it up, side to side. Okay, so can you span out your fingers? Close them, move them up. That's fine. Okay, so now resistance. So usually we ask to the hand grasp. Usually we do that. So just squeeze them as hard as you can. Okay. So if she's squeezing them, that means fine. Usually with stroke patients, that's what we look at because usually they have either left or right sided weakness or sometimes both. So that's why we look for the hand grip. Her hand grip was strong, so that's fine. So now we're just gonna check for resistance. So try to pick it up, and I'm gonna push down and try to pick it up. Okay. 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 On the fingers, span them up. Okay. So span them up. The nails are pink, no problems there. Um, Just dirty. No.
Just dirty.
No, I'm just kidding. No. No, okay.
I wash my hands just like you.
Let me double check. Let me go to the musculoskeletal section real quick, just to check if I'm missing anything. Motion. Okay. We're checking for flexion, a hyperextension on the elbows. Flex like this. The elbows flexing. That's fine. The other one. We check the shoulders. She was able to pick them up. Resistance, we checked that. Strength, 5 out of 5. Bilaterally, wrist, hands, fingers. Okay, we checked that. We checked the nails. We're inspecting. Okay, so her gait, balance, posture, coordination. Right now, she's been sitting down properly. She's able to sit down up with her spine up. No pain issues with that. Let's see. What else on the... Can you make a fist? Adduction. She already spread her fingers. Abduction. Fingers downward. Flexion. Upward. Hyperextension. Okay, that's fine. Okay, so I'm just double checking if I missed anything. Capillary flow. Oh, radial pulse. Usually we check the radial pulse times 2. So I just want to check if it's strong. Strong pulse. Okay.
No.
Strong pulse. Okay, so radial pulse times 2 bilaterally, strong. And just to, cover real quick, there's, of course, more than the radial pulse. We have the brachial pulse, which is up here. Usually with infants, I believe, that's where they check the... You can extend it. Usually with infants, they check the brachial. The carotid would be right here in the neck. Usually we check that for, hospice patients that are terminally ill. We make sure that that's a pulse we usually check to check if they're still alive, basically. Other than that, we have the femoral pulse, which is below the abdomen. We have the popliteal pulse, which is below and back posterior of the knee. We have the dorsalis pedis, which is on top of the feet, on top of the foot, I believe, the anterior part, and then the tibial pulse, which is on the side of the ankle. Okay. Let's see. Okay, so now we can go to the abdomen. Earlier we said about the history of the cholecystectomy, which is the gallbladder. She has a history of that. I wrote down she had pain. This was back in 2006. It was a sharp pain, nausea, vomiting. She had a 3 small centimeter incision. 3 small incisions, 1 centimeter in length. I'm sorry. But other than that, no issues after that, right?
No.
Afterwards, okay. So we would inspect the abdomen first, quadrants, right? So it would be the right upper, left upper, and then the lower, right? Right or left quadrant. Okay, so I think we can check the quadrant, 1 or 2 minutes on each quadrant. Usually like just to hear the bowel sound, so that's what I'm gonna do. Or we can check, I believe it was 5 minutes on the right lower quadrant.
Where? Here? Or where? Where are you gonna check?
Okay. So bowel sounds noted. Times 4 on all quadrants. BL auscultation. What else? So after that, we inspect. We auscultate. We inspected. We ask her any questions like abrasions, going back to the same thing, discoloration, lesions, anything like that. We noted that she has a small, very tiny scar due to her history of the removal of the gallbladder. After that, we just palpate. So right here, I'm just gonna check. I'm gonna tell her to take a deep breath. Now exhale. Okay. So I'm gonna try to hook on the liver to check anything like that. Any enlargement of the liver, any tenderness of the liver, any pain or anything like that. And on the other side, we do the same thing for the spine. So take a deep breath. So everything's fine, not tender, no pain, nothing like that. Okay. And usually on the what was it? The McBurry point, which would be on the right lower quadrant. We're looking at any problems with the appendix, any appendicitis issues, never.
No.
Okay, anything like that. So I remember you were saying that the ER student would say the shuffle appendicitis or anything like that because there's so much pain. So I mean, it's obvious that she has no pain right now. So after, after palpitation, we do percussion. So we're looking for dullness in the liver. So I get my hand and then I tap on it. Okay, dullness, and then we just check every quadrant. Yeah. Okay. So no issues there. Let me just keep looking. All right. So when was? Where did I leave my pen?
Right there.
Oh. When was your last BM?
What?
BM, bowel movement or stool?
Yesterday. Yesterday morning.
And void?
What?
Void?
Oh, about an hour ago.
So today?
Mm-hmm.
Any gastrointestinal issues such as nausea, vomiting, abdominal pain? Any different? Anything different that you've noticed in your GI tract?
No.
Okay, so it was like I said, dullness over liver and spleen, and everywhere else on all 4 quadrants, tympani noted. With percussion, no guarding, no palpable masses present. Palpated liver, deep breath, no issues there. Liver just smooth, non-tender. Everything's fine, no palpable or tenderness. So just something extra that we could do is check, listen for bruits on abdominal aorta. Can you stand up? Well, I'm sorry, just, yeah. Which would be in the middle center section. Renal arteries, which would be on the sides. And then the femoral arteries would be right here in the lower abdomen. We would use the bell of the stethoscope, which is the other side. This is the diaphragm. But we don't need to right now because no current diagnosis leading to that or anything like that or history with it. Okay, so let's continue. Other than that, we have to ask on going back to the private area or peri area, which we call it. Any issues there? Any abnormal discharge? Any pain? Any lesions?
No.
Any abrasions? Anything
No.
abnormal that you've noticed?
No.
Okay. Any hernias? Anything like that?
No.
Okay.
No.
Okay. So usually, like a hernia would be the intestine moving outward of the muscle area, and you could actually listen to bowel sounds. I thought that was really interesting, actually. That we could listen to that. I didn't know that. So any problems there? Nothing.
No.
Okay.
No.
So okay, so now we're gonna look at, like we did the last video on the musculoskeletal, we're gonna look at the walking. So if you can stand up and walk, just walk down to the wall.
To the wall?
Yeah, just go. Okay, so balance evenly distributed on both sides. Come back. Okay, and now do the same thing how we walked on here.
Heels?
Yeah. You know how we did it last time?
Yeah.
And then just walk back. Walk back. Okay. Any problems there?
No.
Now on your tippy toes, that way and back. Okay. Now how I showed you like this, heel to toe. Okay. And then back. Okay. So stay standing up. So balance, coordination, posture, everything seems fine. Balance, like I said, evenly distributed. Good range of motion. Now we're just gonna look at the spine. So just if you can just touch your toes, like we did last time. Okay. So we're looking at the back area. No hump right here for kyphosis. No lordosis, which would be inward curvature of the lumbar area right here, and then scoliosis, which would be the curvature like this and squiggly lines, anything like that. We're assessing, but as you can see, symmetrical, no issues there. So you can stand up. And what else? What else? What else? Okay, you can sit back down. So now I'm just, just making sure I don't miss anything. So we the hips, the knees, the ankles, the feet, range of motion, the hips. That would, like I said, we don't really have a bed that we can try the hip. We would do the hip hyperextension, which we would lay the patient down and we would hyperextend the full leg, and then we would basically like, it would be abduction to the side, hyperextended. Hip flexion, which would be abduction, so coming towards the abdomen. But as you can see, there's no issues there. Knees inspected, they're symmetrical. Popliteal pulse, like I said earlier, would be in the back posteriorly. That's fine. Ankles, feet. Okay, so now can you pick up your knees? Just put them on top. Okay, so all right, so just right there, what she's doing is she's flexing it, right? So that would be dorsiflexion. So if she's would go like this, it would be plantar, right? So we're checking for that range of motion. Here it would be the dorsalis, and then on the side would be the tibial. So we're checking that. So we could check. Let's find the pulse of the pulse times 2 bilaterally, no problems there. No swelling. Ankles are fine. Nails are fine. Can you move your fingers up and down? Just your fingers. No, like put your foot still, and then just your toes. Oh.
What do you mean?
And I told you this is gonna be. I was like, "Are you ready?" Yeah, just just move your fingers up and down.
Mop and sweep the floor.
Up and down.
Yeah.
Okay, so range of motion intact. Usually with like, let's say like diabetes people, we always tell them to check if there's anything between those fingers, because usually they'll have like a painless diabetic ulcer or anything like that we want to check and prevent it from getting worse or anything like that. because usually that's what's meaning that the circulation is not going and coming back from feet to upper body. So that's what we're checking, and we tell them to wash them very properly. But as you can see, the nails are fine. Oh wait, okay, I can check it over here. Is it because she has painted nails, but not all of them? Sorry, but we're checking for capillary refill, and they're fine. No issues there.
See, George.
Okay. So we're checking the inward, outward, adduction, abduction, finger flexion, extension, dorsalis flexion, upper flexion, plantar flexion. We already did. The pulse, swelling, tenderness, nothing like that. So okay. So now put your feet up like this. Okay. So I'm gonna push, and you push it up against it. We're checking resistance. So go for it. Okay. So strong. Go for it. Strong. Okay. Strong times 2 bilaterally. Okay. Let me put these down. All right. So neurological issues. Any problems? Numbness, weakness, paralysis, loss of motor control, anything like that. Dizziness, tremors, confusion.
No.
History, things like stroke.
No.
Alzheimer's, dementia.
No.
We already went over the alert oriented, time, place, memory loss. So I'm going to say 3 words. Blue, red, orange. Repeat it.
Blue, red, orange.
Okay, so we're going to continue like we did last time, and then we're going to ask her if she remembers checking for short-term memory loss or anything like that. We have 12 cranial nerves, so olfactory smell like we did earlier. And everything I've noticed is eyes closed. Why? We don't want her to change their mind because of what they're seeing or anything like that. We want them to close their eyes so we can actually check that she's telling the truth and that she can, basically smell what we're putting. Last time we used the chocolate. She was able to check that it was chocolate with her eyes closed. The visual acuity, the Snellen chart we've done earlier. The Snellen chart, which would be the words. It's just the poster words in the wall, and we're just checking if she can read them. She would cover one eye and then the other one. We've done that before, but like I said, usually we tend to assess on the things where they have history on or diagnosis. So she doesn't have no history on any optic issues or anything like that. So other than the glasses and the stigmatism that she said earlier, though. Other than that, we can check the oculomotor, which was the cranial nerve 3 and 5. No, 3 and 4 abducens. Pupillary response accommodation, we already did that. Cranial nerve 5 trigeminal, we clench your teeth. Can you clench your teeth? No problems there. Okay. We can even check for peripheral vision, which I saw that she was doing this, like in the video, on the side. So just look forward. Let me see if I can do it on this. Okay. So just look forward. Can you see?
Mm-hmm.
Can you see? Okay. So we're just checking the peripheral vision there. Okay. What else? Okay, so how we did in the last video, the Romberg test, so just stand up and close your eyes.
Stand up and close my eyes.
Mm-hmm. Just close it. Okay, so as you can see, she has her eyes closed. Right there and then, she's not leaning forward, she's not leaning backwards, she has equilibrium, she has balance, she has posture, coordination. No problems there. Okay, so we already did this earlier, the pronation drift, which she extends, and then I put resistance, and she was able to resist to the downward motion. Okay, so you can sit back down. So the cerebral function, the coordination, so it was the finger touch, so just touch my finger. Like we did last time. So she's able to see where my finger is going. Sensory system, eyes closed, temperature, sensation, cold or hot. So that's very, very important because with neuropathy, diabetic neuropathy, patients with history with diabetes, they can't really sense cold or hot, which is really bad because, let's say she gets in a hot tub, she can't or hot water or anything like that, and she can't tell how hot it is, it causes burns, anything like that. So the sensory system on the temperature sensation is very important. But she had no history of diabetes.
No.
No history. So cold or hot, they use test tubes. Fortunately, here we don't really have anything we can check other than ice and a hot pan. No, no, I'm just kidding. All right,
No.
so let's just finish with the last test, stereognosis, which eyes closed. So I'm gonna tell her to close her eyes. So close your eyes, stick out your hand, and I'm gonna place something on right here. Okay, and tell me what it is.
It's a pen.
It's a pen. Okay, so she was able to tell. The 2-point discrimination was with, we used it with what was it, the pin we used?
I'm
That
sorry.
was poking you?
It was a
clip.
I think it was a clip.
A clip.
A
Yeah,
clip.
a clip. So those 2 points were pointed with 1. She says 1 point, and then 2 would be 2. And then the graphesthesia. So we tell her to close her eyes, and then I'm gonna write a number.
1,
Okay.
2, 4, 6.
Okay. So she's able to tell. And then the reflexes, which is really important. The reflexes, like we did, we don't really have the correct tool, like I said earlier, but we would check right here. So we would try to have the legs dangling when we check here. So we would check it right here, and we would tap it, and then it would be an involuntary movement for her to move it up, which would be perfectly fine. And then here we can check the bicep. We go like this. It should move, and then the tricep in the back. So those are the ones that we could check on the reflexes. What else? Oh, and can you tell me those 3 words that I said earlier?
Blue, red, orange.
Okay, so no memory loss there, so good. Good thing there. I think we're done. We covered mostly everything. I guess just to add to it, when we check the legs and we tend to dorsiflex on, we're checking for DVT on the calf, any painfulness to the calf, anything like that that you noticed?
No.
No. Okay, or any swelling or hot to the touch. Like I said earlier, we would ask for a Doppler ultrasound that would say like a positive for DVT, and then we would call the doctor, and they usually put them like on heparin or something. Any venous stasis, browning, skin discoloration, we inspected it and there was no browning or anything like that. Right here, so everything's fine. Color is the same from feet to lower leg. What else we would check? Any ulcers, varicose veins also. Varicose would be the very distinct blue veins, squiggly veins that would be like on your lower leg, calf, and that would be sometimes painful when walking. I just want to make sure I covered everything that's important. Going back to maybe the jugular vein or jugular distension, we would ask the patient to lay flat on a bed, and then we would like lift the header of the bed, and as we're lifting it, we would be checking right here for jugular distension, which would be very prominent. I've seen it before. It's very prominent in swelling, and you could tell that there's an issue there. But her neck's fine. You can range of motion to neck. You can pick it up, lower it down, chin to chest, side to side. The other side, no pain, no nothing. Okay. Another thing that we could check is any fluid or anything like that, excess fluid. We could check the fremitus which we would basically, like I did on last time, go like this and say
99.
99. We're checking for vibration or anything like that, any abnormal vibration, but she had normal fremitus anterior and posteriorly on vibration, so that was fine. That's it. Okay, I think this concludes for my video. So thank you very much. I had a good time. And that's it. Thank you.